Hello, and welcome to this PrecisCa mini tumor board on breast cancer. My name is Dr. Reshma Matani. I'm a breast medical oncologist at the University of Miami Sylvester Cancer Center, where I co-lead our breast cancer program. It's my pleasure today to be joined by several well-renowned experts in breast cancer, who I'll now ask to introduce themselves. I'll start with Dr. Shah.
Hello, I'm Chirag Shah. I serve as the Director of Breast Radiation Oncology at the Cleveland Clinic.
Hi, I'm Stephen Poplack. I'm a breast radiologist, professor of radiology at Stanford University.
Hi, I'm Monica Morrow. I'm the Chief of Breast Surgery at Memorial Sloan Kettering Cancer Center.
Hi there, I'm Dr. Sarah Hurvitz, Professor of Medicine at the David Geffen School of Medicine at UCLA, where I'm a medical oncologist specializing in breast cancer.
This is a 47-year-old African woman of Bahamian descent, also with a CHEK2 and BRCA1 mutation, with a history of left breast cancer, triple negative, invasive ductal carcinoma, now presenting with skin nodules after she's received treatment for breast cancer 8 months ago with neoadjuvant chemotherapy, where she was able to achieve a complete pathologic response, and we're being asked regarding recommendations for further management. So let's re-review the patient presentation. Currently, she's status post bilateral mastectomies with reconstruction and presents with 4 raised skin nodules over the right chest wall and left axillary tail, and she maintains a good performance status. In terms of her prior medical history, she has gastroesophageal reflux disease, or GERD. Her GYN history is shown here. She did undergo a risk-reducing bilateral salpingo-oophorectomy at age 46. She has no toxic habits, and her family history is significant in that her maternal aunt had breast cancer and a maternal uncle had pancreatic cancer. This is the view of her bilateral screening mammogram and ultrasound that showed a 3.5 centimeter suspicious mass and a suspicious lymph node. Dr. Poplack, would you like to add anything?
Sure, this is medial lateral oblique, the angled oblique view of the left breast from the screening mammogram. You can see the quality of the mammogram is not very high, and that's because it's a film mammogram that's been digitized. One of the things you lose with film mammography is ability to see the skin line and subcutaneous tissues well. But you can see in the upper part of the image, there's a round mass, dense mass with spiculated margins. And if you look at that in the upper left part of the image, the triangular sail-shaped structure is her pectoralis muscle. In the highest leftmost part of the image, you see at least partly imaged is one lymph node. Hard to know whether that lymph node is suspicious based on this view alone.
Thank you. So she does undergo an ultrasound-guided core biopsy of the left breast mass and the axillary lymph node. The breast biopsy reveals invasive ductal carcinoma, again, triple negative, grade 2, with lymphovascular invasion. The lymph node biopsy, however, is negative. A breast MRI reveals the index mass at 10 o'clock at 3.5 centimeters, again, with an abnormal appearing lymph node, but recall the lymph node biopsy was negative. She undergoes genetic testing appropriately given her family history and young age, and is found to have a germline mutation for both CHEK2 and BRCA1, and initiates neoadjuvant chemotherapy with doxorubicin cyclophosphamide followed by paclitaxel and carboplatin. And then at the time of mastectomies is found to have, and sentinel node biopsy is found to have a complete pathologic response. As stated earlier, she undergoes a prophylactic BSO, which is negative for carcinoma, and then shortly thereafter is found to have on skin punch biopsies of the left axillary tail along with the right chest wall. She's found to have lesions that are unfortunately biopsy proven, recurrent invasive ductal carcinoma with the same prognostic markers, grade 3, and staging workup confirms no evidence of distant disease. So a very general question here about further management recommendations, a lot to unpack here in this case. Why don't we start with the medical oncology aspects of the case? Dr. Hurvitz, can you comment on the use of neoadjuvant chemotherapy here, the addition of carboplatin, and how you make that decision? And also, if the patient had been seen today, is this a patient that you would have considered adding immunotherapy in the neoadjuvant setting?
Yeah, it's an interesting case. She did achieve a pathologic complete response from anthracycline, taxane, platinum-based therapy, which was a great outcome. And we would predict that patients with that type of response to therapy have a pretty good chance of not having an invasive disease recurrence in the next 3 years. Unfortunately, that's not 100%, and this patient had a recurrence. In general, the use of platinum-based therapies with taxanes in the neoadjuvant setting it's gaining steam. In fact, at ESMO last week, they presented the brightness study, the follow-up of this study looking at taxane with platinum, taxane alone, or taxane platinum and PARP inhibitor in triple negative breast cancer that wasn't just for BRCA mutation carriers. And the addition of the platinum to the taxane improved path-CR rates as well as event-free survival. The addition of the PARP inhibitor didn't add much. This is one study adding to mounting studies indicating that platinum will improve the path-CR rate in patients with triple negative disease. And so in my own practice for triple negative breast cancer, I will use a platinum-based approach. And I like Priyanka Sharma's regimen of docetaxel carboplatin for 6 cycles prior to surgery if the patient has node negative disease that's triple negative. If they have a path CR, then I even try and omit the anthracycline. If they do not, then use of the anthracycline is certainly indicated. Now we have, as of this summer, the use of immune therapy, as you mentioned, and the immune therapy should be given with an ACT platinum-based approach, as it was in the Keynote trial. The use of pembrolizumab, when added to the type of regimen this patient had, does improve the chance of path CR, and it also improves event-free survival. And these data led to the FDA approval of this regimen. So given the fact that the tumor was greater than 2 centimeters, suspicious node, although biopsy negative, I think the use of an immune checkpoint inhibitor could certainly be considered in the neoadjuvant setting for a stage 2A triple negative breast cancer. And then in terms of management for this patient now, I know we're going to be talking about radiation therapy, which I think is an important component. The use of systemic therapy in a patient who's already had anthracycline, taxane, platinum, and recurred about a year or so after surgery is sort of a data-free zone. We could certainly suggest the use in a case like this of a PARP inhibitor. One might consider reutilizing taxane platinum since it was just over a year since the last receipt of chemotherapy. Some might use something like gemcitabine platinum, but in this patient with BRCA1 mutation, I would probably lean toward a PARP inhibitor type of therapy.
Mm-hmm. Thank you. Now, you mentioned the use of radiation. As you also mentioned, she had a PCR and we would have predicted that she would have done well, but yet she developed a recurrence, and this was in the right chest wall and left axillary tail on skin punch biopsies. Presumably, she didn't receive initially post-mastectomy radiation. The initial imaging did show an abnormal lymph node, but the axillary node biopsy was negative. So Dr. Shah, I'm assuming that this is a patient that you would have not offered initially post-mastectomy radiation initially.
Yeah, thanks, Dr. Montani. Yeah, I mean, I would say it's probably standard of care not to recommend radiation in this case. She was a clinical T2N0 with a negative biopsy prior to chemotherapy and a pathologic complete response. There is some data, albeit I wouldn't consider it the strongest data, to consider post-mastectomy radiation in T1, T2 node negative, triple negative breast cancers. But that data hasn't been validated. And in the current situation, given that she has 4 nodules across the bilateral chest walls, I'll usually consult with one of my surgical colleagues, but we usually don't consider this surgically operable. And what we've done in our institution in cases like this is often start with systemic therapy. And if there's no signs of distant progression beyond the skin, actually offer consolidative radiation. We often use a regimen of Xeloda in conjunction with radiation therapy. I usually dose escalate to about 65 to 70 gray. And then to the skin nodules, I'll actually give concurrent hyperthermia as well. And this is based on a couple studies showing outcomes with including our own that have published. So there are some patients that we've seen in this that are actually able to have long-term disease-free intervals with that type of approach.
Thank you. And so, Dr. Morrow, could you comment on the case from your perspective in terms of the initial management as well as how you would approach the patient now? And I think as Dr. Shaw alluded to, would you be considering this a situation where we would be offering treatment with curative intent, or are we dealing with more of a palliative situation given that she has skin involvement on the contralateral side? Are you less optimistic?
Thank you. Well, in terms of her initial surgical management, it was completely appropriate. We know that these women have a high risk of contralateral breast cancer, and we know that there are not a lot of maneuvers beyond surgery that will reduce that risk in any substantial way. So while patients don't have to have bilateral mastectomy, if they have a BRCA mutation, and in this case, a CHEK2 mutation as well, it's certainly an option for those who want to minimize their risk. And there are some retrospective studies that show that after 10 to 15 years of follow-up, you see a mortality improvement. So you have to survive your first cancer before you see that mortality benefit from the contralateral mastectomy. But her management was standard, and has been alluded to, when you have a PCR, not only does it bode well in terms of distant disease, but it's usually associated with a lower risk of local regional recurrence as well. I think one thing to emphasize in this case, which was quite appropriate, was the metastatic workup, because we know that when patients have a local recurrence, whether it's a chest wall recurrence like this, or an in-breast recurrence after lumpectomy, that 20 to 30% of them will have synchronous distant metastases. So before launching into aggressive surgery, you need to be sure you're not dealing with metastatic disease. In this case, I would agree with Dr. Shaw that I do not believe there is any role for surgery here. It's wishful thinking that you are getting rid of all the cancer when you know that the lymphatics are seeded all the way across the opposite chest wall and into the axilla. So we reserve surgery in the case of chest wall recurrence for isolated chest wall recurrence, solitary nodules, or perhaps a couple small nodules in close proximity to each other. But once it's scattered around the chest wall, then radiation is clearly the mainstay of treatment. But overall, I'm not optimistic about this case. The disease-free interval was very short. She had maximal treatment to start with, which was appropriate. And here she is, recurred already.
Thank you. Before we move on from this case, Dr. Hurvitz, I'll just ask you this question because I think it comes up quite a bit in tumor boards or in educational discussions. I personally haven't been in this situation. In a patient who has metastatic disease, triple negative, and is PD-L1 positive, but also has a germline BRCA mutation, how are you sequencing PARP versus first-line immunotherapy with chemotherapy now that we have long-term outcomes from trials like the Keynote study looking at the use of Pembro in the metastatic setting, showing long-term outcome benefits?
Yeah, you bring up and in the metastatic setting, I generally will use immune checkpoint inhibition in the frontline setting because we know immune checkpoint inhibitors are most effective in the frontline setting. And then at the time of progression, we'll incorporate the use or switch to the use of a PARP inhibitor. We have talazoparib and olaparib available to us as single agents. And that's where I would, that's how I would sequence it. Another question that comes up is, if this type of patient is presented to us now and is in the neoadjuvant setting, and we use therapy, which isn't dependent on pediatrician in the neoadjuvant, you can use it in combo with chemo, and the patient has residual disease, do we continue the pembrolizumab, use olaparib, because both are now available to really guide the selection here? I think we're struggling, and new questions are generated every go and waiting for the evidence to catch up.
Thank you.